This is the 10th in a series of videos on glaucoma training. Module 10, Assessment of the Visual Field. The learning objectives in this module are to understand the changes that occur in the visual fields due to glaucoma, to know how to test the visual field, and to know how to interpret a visual field plot. Testing the visual field plays an important role in the detection of glaucoma by giving you the opportunity to identify visual field defects that indicate the presence of glaucoma. Improving your recognition of visual field defects associated with glaucoma and confidently interpreting test results will ensure that you can effectively evaluate the suspected cause and severity of vision loss in glaucoma suspects and glaucoma patients. Testing the visual field is an essential part of the investigation and diagnosis of glaucoma suspects. It is also vital when monitoring the progression of the disease in diagnosed glaucoma patients. Significant visual field defects can be present in glaucoma patients long before they notice any changes in their vision. Confrontation visual field testing. Early or even moderate visual field defects are unlikely to be detected by confrontation visual field testing, particularly if only one eye is affected. Therefore, glaucoma will be advanced if this test discovers a loss of visual field. A useful test to check for vision loss in stroke, but it's of limited use for glaucoma screening or monitoring. The NICE guidelines NG81 for use by optometrists in the UK states that for patients with ocular hypertension or suspected glaucoma, NICE recommends a central visual field assessment using standard automated perimetry, either full threshold or suprathreshold, to establish whether any visual field defects consistent with glaucoma are present. They advise repeating the test on a separate occasion to confirm the accuracy of the results. There are three main perimetric methods used to detect visual dysfunction in the central and peripheral vision. They are kinetic, static, either threshold or suprathreshold, and frequency doubling technology. Standard automated perimetry, also known as white-on-white perimetry, is currently the most common type of visual field testing. It is a term used to describe static testing in both threshold and suprathreshold testing forms. The threshold refers to the dimmest light stimuli that can be seen at retinal locations in the visual field of each eye. Static perimetry uses stationary lights at evenly spaced intervals that are presented intermittently to detect visual field loss. This widely used automated test uses white-on-white perimetry, a white stimulus against a white background, to test retinal ganglion cell populations. The image on the slide shows a Humphrey field analyzer. An algorithm is used to establish the local threshold with flashes at varying intensities until they are detected by the patient. Different locations within a given region of the visual field are tested until the threshold, or the stimulus intensity seen 50% of the time, is seen at each test location. Calculation based on age-matched normal data is used to inform the results. The full threshold strategy measures the intensity of a stimulus that can be detected by a patient 50% of the time and is considered the gold standard in glaucoma detection and management. A choice of computer algorithms is available. The most common test, the central 24-degree or 30-degree of visual field. The intensity of the light stimulus is varied until the dimmest target the patient can see, that is, the threshold, is found at each point and mapped out on a grid. The sensitivity is the reciprocal of the threshold and is recorded in decibels, dB. The higher the decibel value, the higher the retinal sensitivity. Full threshold automated perimetry yields greater quantitative data about the threshold across the visual field than suprathreshold static perimetry. This enables the comparison of measured data with age-matched data available in the perimetry software and is useful in the detection of change. The test usually takes around 10 to 12 minutes per eye. Because it is time-consuming and complicated, user experience is required. Patient fatigue is common due to the length of the test, and high variability can be an issue. It is therefore unsuitable for screening. Suprathreshold. This is a rapid static testing method that is ideal for screening. It is easy for patients to engage with and highly reproducible. However, it may miss shallow defects and lacks quantitative information on defect depth and the degree of visual function. Suprathreshold stimuli are brighter than the threshold stimuli detected by the patient. During analysis, the intensity of the stimulus target is not reduced to the level of detection or non-detection. Suprathreshold testing is not validated for monitoring, so is not advised for use in monitoring schemes. It is designed for the detection of moderate to severe defects and is therefore appropriate for screening. CETA, the Swedish Interactive Thresholding Algorithm, is an advanced algorithm for threshold estimation, usually combined with an automated perimetry test to determine the visual field in a more efficient manner. The CETA algorithm determines perimetry thresholds by continuously estimating what the expected threshold is based on the patient's prior response, age, and neighbouring thresholds. This optimizes efficiency. It can reduce the time necessary to determine the visual field by up to 50%, taking about 7 minutes per eye, which in turn decreases patient fatigue and increases reliability. CETA mode is now widely used in many computerized automated perimeters. CETA fast. Test time can be reduced by a further 30% in CETA fast mode, taking just 4 minutes per eye. CETA fast is useful for screening. While CETA standard should be the first choice for the evaluation of glaucoma suspect and glaucoma patients, the CETA fast algorithm can be useful for those patients who fatigue easily. However, note that the faster program can underestimate the severity of scotomas. Frequency doubling technology, FDT, is a portable perimetry test designed for the rapid and effective detection of visual field loss. It has good levels of sensitivity and specificity and is effective in the detection of early glaucomatous damage. FDT can selectively detect loss of function in certain parts of the nerve fibre layer. Sensitivity results are reported in decibels. The patient is presented with different flicker targets, and presses the response button at the appearance of each stimulus. To avoid temporal transients, the stimulus is presented for under a second, in which contrast is gradually ramped up, held at the required value, and then gradually ramped down. FDT perimeters can be used for suprathreshold and threshold testing. In glaucoma, there are two main types of visual field loss. Localized loss that manifests itself in nerve fiber bundle defects, such as an arcuate defect, a nasal step, or a paracentral scotoma. Diffuse loss of sensitivity that scatters widely across the visual field but is often difficult to distinguish from other visual defects. Getting to know the distinct features manifested by each will help you to identify signs of glaucomatous damage during the visual field test. Visual field defects that can indicate glaucoma often develop gradually. The earliest sign is an increased scatter of depressions. The asymmetry between the eyes is another early indicator which can develop over time from a permanent paracentral loss to an arcuate and eventually hemifield loss. Advanced sight loss is characterized by tunnel vision with residual areas of slight vision in the periphery. This slide shows some of the early visual field signs of glaucoma. Increased scatter, paracentral loss, arcuate or hemifield loss, and tunnel vision with residual sight in the periphery. Nerve fiber bundle defects. Localized visual field defects in glaucoma are a result of damage to the retinal nerve fiber bundles. Paracentral, arcuate, and nasal step are all types of nerve fiber bundle defects, and all have specific characteristics indicating glaucomatous damage. However, it is important to note that nerve fiber bundle defects can also be caused by other ocular conditions, such as optic nerve head drusen, congenital optic nerve head pits, optic nerve collibomas, tilted discs, and anterior ischemic neuropathy. Paracentral defects. Located near the center of the visual field, paracentral defects follow nerve fiber distribution and are an early sign of glaucomatous damage. They tend to have sharp edges. A paracentral defect can appear to abruptly discontinue at the horizontal midline. A paracentral scotoma is an island of relative or absolute vision loss within 10 degrees of fixation. Arcuate defects. More advanced than paracentral defects, arcuate defects develop when paracentral scotomas coalesce, forming a curve from the temporal field to the nasal field. This eventually results in a hemifield defect. Arcuate defects are narrow in the temporal field because the nerve fiber bundle converges on the optic nerve, but spreads out on the nasal side. Arcuate defects are limited by the horizontal midline, stopping abruptly when they reach it. Arcuate defects can be in the superior or inferior field. Nasal step. A nasal step describes the difference in sensitivity above and below the horizontal midline and is highly specific to glaucoma damage. It can occur in association with arcuate and paracentral scotomas or in isolation. The step-like defect along the horizontal midline results from asymmetric loss of nerve fibre bundles in the superior and inferior hemifields. Diffuse defects. Diffuse depressions of the visual field are caused by a widespread sinking of the island of vision, often reflecting a loss of the nerve fibres of the retina. This uniform reduction in sensitivity can be difficult to distinguish from other causes, such as cataract, miosis, or uncorrected refractive error. Identifying glaucomatous visual field defects. Rules to assist identification of definite glaucomatous loss are depth. Deep defects are more likely to be real. Position. Glaucomatous visual field defects are found in characteristic locations. Pattern. Nerve fibre bundle. Arcuate. Nasal step. Paracentral. Sector or temporal wedge. Clustering. More than 2 abnormal test locations are more significant. And repeatability. Definite defects are repeatable, although they can vary in depth. This slide shows the various glaucomatous visual field defects you may come across. Nasal step, temporal wedge, an established superior arcuate defect, an early superior paracentral defect at 10 degrees, a superior fixation threatening paracentral defect, superior arcuate with peripheral breakthrough and early inferior defect, tunnel vision defect with temporal crescent sparing, and end stage complete field loss. Carrying out visual field tests. To obtain reliable test results, you should take care to ensure accuracy in the visual field perimetry test from the equipment, patient positioning, and patient comfort. The patient should wear their reading prescription during the test. Remove any distractions in the area around the examination and ensure that the patient is aligned properly to the analyzer to help reduce fixation losses. It can be helpful to explain the test procedure clearly and reassure your patient that they can blink normally and relax throughout the test. This helps to maintain concentration on the fixation target and increase the reliability of results. For patients who cannot see the central target, a small or large diamond pattern of 4 lights can be used. The patient looks into the center of the 4 lights. The Humphrey Visual Field Plot. The Humphrey Visual Field Analyzer produces a detailed plot which provides a wealth of information. Note which testing algorithm, 24-2, 32, etc., was used so that the same test type can be used in future examinations. This is a typical report following a Humphrey visual field test. Interpreting the visual field plot. Numerical decibel graph. This chart records the raw sensitivity values in decibels. 0 decibels means that the patient could not see the brightest threshold and has low sensitivity, while 50 decibels indicates that the dimmest threshold was seen and the patient has high sensitivity. Most values are around 30 decibels, and any numbers below this range imply a possible visual field defect. Grayscale. The grayscale graph represents the numerical decibel data in a visual format. Values closer to 0 are black, transitioning through shades of grey to those close to 50, which are white. While it is a useful indicator of areas of interest, such as potential scotomas or depressions, it has little value in analysing the extent of glaucomatous damage, as it may overestimate or underestimate defects. For a full clinical picture, the total deviation and pattern standard deviation plots must also be examined. The total deviation plot compares the patient's visual field plot with age-specific normative data. It shows all the portions of the patient's visual field that are different. It is a key graph which is most easily assessed by using the probability plots with the shaded boxes at each test location. Solid black squares indicate test points that are statistically more likely to be abnormal compared to the other lighter shades of grey. Localized defects will appear on the TD plot, but may be hidden by a generalized depression. To separate a potentially glaucomatous localized defect from other defects, the pattern deviation plot must also be examined. Pattern deviation reflects irregularities in the field, such as those caused by localized field defects. The PD plot highlights localized defects by removing generalized visual field loss that could be the result of a cataract, say. Glaucomatous defects that are present on the PD chart are usually characterized by their shape and location, i.e. nasal steps, central and arcuate scotomas. Global indices, mean deviation. Mean deviation shows how much, on average, the whole field varies from the normal value expected for the patient's age. The more negative the value, the greater the loss of sensitivity. Typically, a mean deviation of -2 decibels or less is suspicious. The mean deviation is a representation of the depressed vision for each point when compared with age-matched control data. It gives an overall value of the total amount of visual field loss. Global indices pattern standard deviation. Pattern standard deviation reflects irregularities in the visual field, in particular those caused by localized field defects. PSD is a useful quantification of the amount of loss and the progression of glaucoma in the early stages. However, the PSD is not suitable for tracking advanced glaucomatous defects. A high PSD indicates a greater irregularity, and as glaucoma advances, the PSD may appear to improve due to global depression. Glaucoma hemifield test. The glaucoma hemifield test comments on vertical asymmetry and measures result against a normative database. It compares points in the upper field to corresponding points in the lower field and interprets the results as belonging to one of three categories. Outside normal limits, indicating the upper and lower fields are different, which may signify glaucoma. Borderline, or within normal limits, indicating glaucoma is unlikely to be present. It also indicates general sensitivity. Reliability indices. There are three commonly used reliability indices used to assess the quality of your test results. Fixation losses, false positives, and false negatives. These should be taken into consideration when assessing the visual field printout. An error rate of as little as 5 to 10% across the reliability indices can significantly affect the appearance of a defect on the visual field printout, making the grayscale and other plots appear better or worse than they really are. In the past, a 33% error rate was deemed acceptable, but this guideline is no longer valid. Gaze tracker. The gaze tracker is a useful reliability measure indicating how well the patient fixated on the target during the test. It's a useful fixation tracking tool. However, direct observation of the patient's fixation should be used in conjunction with this for the most accurate interpretation of the reliability of the field test. Fixation losses. Fixation losses occur when the patient indicates that they have seen a stimulus that is presented in the predicted area of the physiological blind spot. A key fixation loss indicator is the gaze graph found at the bottom of some visual field plots, showing the quality of fixation and monitoring blinks. High fixation losses of more than 15 to 20% indicate that the test results are inaccurate. Many automated field analyzers use the Heil-Krakow blind spot monitoring method, which periodically shines a stimulus into the blind spot area and then measures whether the patient responds, indicating they are not fixating on the stimulus if they do. Eye movement recorders are occasionally used to monitor the gaze and ensure it remains fixated on the target. False positives. If your patient responds when no test stimulus is being presented, a false positive response is recorded. False positive values greater than 10% suggests an unreliable test that makes the visual field look clearer than it actually is. For example, it can mask or minimize an actual scotoma. A high false positive and a high rate of fixation loss will also occur if the instrument records fixation losses by presenting stimuli in the blind spot. Let your patient know that they won't always see a light to help minimize false positives. It is useful to note that false positives have no relationship with the extent of loss, and 70% of patients do not register them. False negatives. If your patient fails to respond to a stimulus presented in a location where a dimmer stimulus was previously seen, a false negative response is recorded. This usually occurs due to fatigue or a lapse in attention. False negative values of 10 to 15% suggest test unreliability. A high false negative rate is likely to suggest that the patient's visual field is not as depressed as suggested by the test result, so a repeat test should be considered. However, it should also be noted that patients with significant visual field loss, including scotoma with steep edges, can demonstrate high false negative rates that do not indicate unreliability. This effect appears to arise from the presentation of stimuli at the edges of deep scotomata, where short-term threshold fluctuation can be quite variable. Identifying artifacts is important. Commonly occurring ones are the learning effect. Some patients may take a time to get used to the test. Repeat tests can show a very different second test, but by the third, they may become much more consistent. Fatigue, particularly in a longer test, will adversely affect performance so it is recommended to test the eye of particular interest first. A faster test, for example with CETA, will also minimise the chance of fatigue. Droopy lids, resulting in superior field defects. You can tape the lid to reduce the effect. Another commonly occurring artifact, lens rim artifacts. Whilst it is important to correct any reading prescription, artifacts can be present due to the lenses or frame used. To reduce this, using the patient's own spectacles or full aperture trial lenses can help. Consider repeating the test if artifacts appear to have had a negative impact on the quality of the results. The diagram on the right shows the grayscale graph with some lens rim artifacts. So we can look at case study 1 with Janet Smith. Testing the visual field is an essential part of the investigation and diagnosis of glaucoma suspects. Look at Janet's visual field results and note down your observations, considering what we have found out about her so far. The right eye shows a generally normal field, with possible slight enlargement of the blind spot. The glaucoma hemisphere test is within normal limits. The left eye shows superior nasal and central loss, and the GHT is outside normal limits. We can go back and look at that. Here is her left eye. Case study 2, Richard Palmer. Look at Richard's visual field results and note down your observations, considering what we have found out about him so far. This is Richard's right eye plot. Have a look at all the different test results and then look at his left eye results as well. You will have learnt by now that to take into consideration all the different presentations and results is essential to get an accurate assessment of whether your patient is showing glaucomatous visual field defect or not. So in Richard's right eye, the pattern deviation plot is fairly full, except for a suspicious area in the superior field. And in his left eye, the pattern deviation plot is fairly full, with a couple of isolated missed points. This was the right eye, and this his left eye. So, knowledge check. What do the numerical data suggest about Richard's visual field? That Richard has a significant visual field defects, that the results are borderline in both eyes, that the right field is borderline, or that there are no significant signs of visual field loss. The correct answer is that his right field is borderline. There is some suspicious darkening in the superior field of the right eye, which could require further investigation. However, it could also be an artifact, in which case a repeat test would be recommended. What is the most likely cause of the artifact? Lens rim artifact, the learning effect, droopy eyelids, or fatigue? The correct answer is droopy eyelids. And in summary, since significant visual field defects can be present in glaucoma patients long before they notice any changes in their vision, the visual field test plays a particularly important role in the early detection of glaucoma. When testing the visual field, it is particularly important to look for the distinctive patterns of loss that characterize glaucoma. Look at all the information on the visual field plot when clinically evaluating the results, and remember that genuine visual field defects are repeatable. Conducting the test again is recommended before referral, especially in equivocal cases. Make sure that you have achieved the learning outcomes for this module. They were to understand the changes that can occur in the visual field due to glaucoma, to know how to test the visual field, and to know how to interpret a visual field plot. Make sure that you have any questions answered.